Hello, everyone, and welcome to my midterm review. This is Dr. Nyla Fleming, and we'll go ahead and dive right in. You guys have covered a lot of information this semester so far, and I want to make sure that I acknowledge that. I know this has been a lot of work, and you may feel like a lot of information is coming at you pretty quickly, and that's because it is. I also want you guys to keep awareness of the fact that everything that you have covered so far is fair game for your examination. Please take some time as you prepare for your exam to review the supplemental learning that has been supplied to you. Again, anything that has been added to this course should be reviewed. If I provided you with any feedback on your class discussion, make sure you go back and review that. Typically, when I'm asking you questions, I'm actually pointing you towards some very key information that I would expect to see on an examination in clinical practice or on your future F&P boards. Additional study tips, and this would apply again for this exam, for your future clinical practice and your F&P boards, is you always want to make sure you have an understanding of epidemiology, have an awareness of typical symptoms, know what are the predisposing factors for any illness, know how to manage an illness, and this includes medication management, know when a referral is indicated, and always be ready to provide patients with instructions. Patients are going to have questions, and be prepared to break that information down into layman's terms. The first area that we will cover is obesity. You will need to know how to come up with a BMI, so just have a basic awareness of that. You will also need to understand how a person becomes obese. The biggest reason why people become obese is because the output doesn't exceed the intake. So that means you're consuming more calories than your physical activity is able to compensate for. So if you're sedentary or you have insufficient activity, you will notice a weight gain. Some people also have a genetic predisposition to weight gain. Other possible causes for obesity include pharmaceutical agents. So some medications can be an appetite stimulant for patients. Hormonal medications, specifically the progesterone-only birth control preparations, can cause women to gain weight. Cardiac medicines, such as beta blockers and certain diabetes medications, can cause weight gain. Other causes for weight gain can be things such as stress or inadequate sleep. Food quality also matters. So people that are living the lifestyle that you guys are right now, which means you're probably working at least part-time, you guys are managing families, world stress right now, we're in the middle of a pandemic, you're extremely busy, you're probably not getting as much sleep as we would like, and sometimes our food choices aren't as good as we would want them to be, and all of those things can cause you to have a weight gain. So let's look at a practice exam question. A patient arrives to your office for an initial evaluation of obesity. Which of the following should be considered in your differential diagnosis? A sedentary lifestyle. B, pharmaceuticals associated with weight gain. C, hypothyroidism. D, PCOS. Or E, all of the above. And the answer is sedentary lifestyle definitely contributes to weight gain. Medications can attribute to weight gain, hypothyroidism, and so can PCOS. So the answer is all of the above. And definitely be very careful with those all of the aboves. I made this one pretty easy, but when you see this on an exam or on your boards, just make sure you read through each of the questions very carefully. Next area that we'll cover is disease prevention. This is something that nurses do extremely well, and medicine has made a switch to covering disease prevention. This is nursing, guys, so just know this is something that we had covered long before medicine had it on their radar. I've included some links You'll also have access to the PowerPoint. It's important to not only know what the adult preventative schedules are, but to know how to access them and know how to read the guidelines. So in each of these links, you will be able to pull up what the current recommendations are. Screening recommendations, you'll be able to pull those up. And also the cancer screening guidelines, I have those pulled up for you as well. The big things I want you guys to remember is breast cancer screening. That one begins at age 40 in women with few to no risk factors. You should know when cervical cancer screening begins. You should know your colorectal guidelines and also your prostate ones. Those are ones that you will see often in primary care. Routine health screenings. In primary care, you need to know what happens when. So that goes back to the previous slide. Make sure you are meeting the age-based requirements of routine screenings. During each exam, you should look at height and weight, consider obesity. We should look at skin. You should do some screenings for substance abuse and mental health. These are really big right now, considering the pandemic that we are in and the stress that people are living under. Safety assessments are big as well, not just because of the pandemic, but if people have firearms in their home, you want to make sure that they have adequate education and the ability to store those firearms correctly. We look at heart and bone health, diabetes screening, reproductive health. You do ears, eyes, and throats. You make sure you cover these things at minimum in every physical exam. Another area that you may be expected to have some expertise in or expected to provide some guidance for your patients would be for a surgical clearance. For this, you will have a physical exam and it will be focused on the type of surgery and the type of anesthesia that is expected for the patient. So if it's something relatively minor, the expectations of the physical exam will be much less. You want to make sure you have vitals included. Make sure we do things such as evaluate the airway and dentition. It is important to know whether or not your patient has dentures, especially when you're going in for anesthesia. And again, the clinical exam will be guided by the type of surgery. Next, HEENT. We'll do a lot of this in your clinical practice. The first area I want to discuss is conjunctivitis. There are 3 types of conjunctivitis that you will likely see in your clinical practice. Patients will come in often with eye complaints, and most people will think they have pink eye that requires antibiotics, but it is your decision as the clinician to decide whether or not that should happen. So first, let's look at bacterial conjunctivitis. With bacterial conjunctivitis, you expect to see some purulent discharge, mild, possibly lymphedema, usually no itching. If a person has viral conjunctivitis, you expect the discharge to be clear with minimal itching. If a person has allergic conjunctivitis, clear to mucoid discharge. There may be some lid edema, and there's probably going to be some itching. So itching is something that will help you distinguish the types. The discharge will also help you distinguish the types. Once you've decided the type of conjunctivitis that the patient has, medication is important. There's Polytrim, which is the first one here, and ofloxacin is what we would use for bacterial conjunctivitis. Ofloxacin would be preferred for someone that wears contact lenses. So you want to make sure that you have the correct bacterial coverage. Viral, we're not going to do much for that. It's really supportive care. If a person has allergic conjunctivitis, you will do topical eye drops, which are allergy eye drops, and many of those are going OTC at this point. Here are some images for you to review. The image on your left is bacterial. The image on your right is probably viral. I take that back. The image on your right is also bacterial. So these are both two presentations of bacterial conjunctivitis. And what's helping me distinguish that is the increased redness here. Um, yeah, and it's unilateral. So I'm thinking more bacterial conjunctivitis in both of these slides. This is a clinical pearl and a test tip. I've taken several board examinations, and each time I think I saw something like this. One of your medication choices to treat a conjunctivitis in a patient will be a steroid. The reason you never pick the steroid is because in primary care, we should not be prescribing eye steroids for patients. The reason for this is because there can be sight-threatening complications because of prescribing the patient that medication. So we leave that to the eye experts. So just remember, no. Next area, otitis media. You'll see this a lot in clinical practice. It's very important to know the top causative agents. You will see this on your board examinations. I can almost guarantee that you will see this question. The top causes are S. pneumo, H. flu, and M. catarrhalis. Commit those to your memory. Treatment recommendations are typically with an adult will be augmentin. If the patient is allergic to penicillin, then we move on to Omnicef. If they're allergic to penicillins and cephalosporins, we would move on to doxycycline. These are images of otitis media, and my personal recommendation for all of you is in your clinical practice, look in all of your patients' ears. The more ears you look at, the better you become at performing that examination. Next, we'll quickly look at sinusitis. Patients will come in quite often with complaints of sinus infections. And what you know from your study is that most sinus infections are actually viral and they will resolve on their own. Viral sinusitis will typically resolve in about 10 days. And what we provide is supportive care. If we're concerned that the patient actually has a true bacterial sinusitis, we would give antibiotics. Preferably, I recommend that you wait for at least 7 days, hopefully 10, before you would begin an antibiotic. The recommendations are augmentin, first line. Second line, if they're allergic to penicillins, are listed here. So we can think doxy, we can think others as well. So it all depends on your patient, their allergies, and the setting. But the big thing to take away is that most sinus infections are viruses and they will get better on their own. A major clinical pearl is that macrolides, or azithromycin, or the Z-Pak, and sulfa drugs are not recommended for the treatment of sinusitis anymore because of the high rates of S. pneumo resistance. Patients want their Z-Paks because Z-Paks are easy. The conversations that you may have to have with patients about why you cannot give them a Z-Pak can be very contentious and very difficult. And I find that sometimes patients look exactly like this guy on the screen. But usually with plenty of education, if we stick to it long enough, they understand and they'll do the supportive care or take a different antibiotic. Next, we'll look at strep. You will see lots of sore throats over the course of your career. The classic symptoms of strep, you'll need to know those. Many times you will have the option of checking a rapid strep. Other times you will not have that option or it won't be clinically necessary. So the big thing I want you to remember is that the absence of cough is something that you will see with strep throat, but it's not 100%. When it comes to testing and when it comes to your future board examinations, the absence of cough is a hallmark symptom. First line treatment is penicillin if they are penicillin allergic, cephalosporins, or clindamycin. And the reason that we give antibiotics is to reduce the complications associated with strep. These are images. This white area here on the left, that is exudate. On the right, this is a pediatric throat. Those are petechial hemorrhages. That is something that you'll see it more in pediatrics than adults, but the petechial hemorrhages is a hallmark symptom of strep. So let's do a practice question. RB is a 19-year-old college student. She has a sore throat and believes she has strep throat. All of the following symptoms are consistent with strep throat except A, tonsillar exudate, B, anterior cervical lymphadenopathy, C, fever of 101, D, a cough. This is the easy one, guys. The answer is cough. Now let's review respiratory symptoms. Pneumonia. I do want to say that this is an instance where I want you to focus on the information that is within your book and not to become distracted by what you are seeing right now because of the COVID-19 pandemic. COVID-19 has changed some of the way that we may look at pneumonia. It may change your differentials, but for the purpose of this examination, focus on what's in the book. This is a situation where the real world has progressed faster than what the book has. So it'll take some time for the textbooks to catch up with what we are seeing now. So pneumonia can be acquired in the community. It can be related to a hospital visit. It could be related to time spent on a ventilator. The symptoms: fever, chills, or rigors, not feeling well, and cough with or without sputum production. The patients may have difficulty breathing. The exam may reveal some rales, which are also known as crackles. There may be consolidation on percussion. And this is something that, as far as what's prevalent in your area in clinical practice, that is something that you would be expected to know. The management is based on the patient. For low-risk patients, macrolide antibiotics may be recommended. Doxycycline is also a secondary recommendation. Next, we'll move on to bronchitis. Most of the time, bronchitis is a virus. 90%, at least 90%. The symptoms are bothersome to the patient, but most people will be fine and they will recover within 3 weeks. Treatments are supportive, so fluids and rest, cough suppressants. We don't necessarily give inhalers to every patient with bronchitis. We reserve that for patients that are having wheezes. Education is extremely important. Patients should know when to return, and they should also know how long they should expect to be sick. Next is asthma. The big thing about asthma is we want to focus on reducing impairment and reducing risk. We want to make sure that the patient has an excellent quality of life, and we want to make sure that we control their symptoms and avoid triggers. We want to do everything that we can to keep these patients out of the hospital and are able to live a life that is as normal as possible. It's important that you know how to categorize asthma. I have provided this chart for you here. I recommend that you actually commit this to memory because you will be expected to recall this on many occasions. I've included some asthma references. You can go back to the PowerPoint and you'll be able to open these up. I've also included a really informative video from YouTube. There is a group called Osmosis. I really like their videos. They do a really good job of explaining very complex medical processes. They use medical terminology, but it's made for a clinician, but it does an excellent job of explaining things very quickly. Next is dermatology. Skin assessment is huge. Expect to see this on exams. Expect your preceptors to ask questions about this. Expect to see this on your boards. A, B, C, D, E. This is what you look for in a normal. This is what's abnormal. Is it asymmetrical? Is the border smooth? What's the color? What's the size? Is it changing? Is it evolving? You will need to know this on every patient that you look at, every mole that you evaluate. You should be able to rapidly recall this information. These are examples of skin abnormalities. We'll move on to dermatitis. And again, I know I'm moving through this quickly, but I'll attach the PowerPoint so that you guys can go through and look at it at your own rate. So there's 3 different types of dermatitis. You should be able to identify all 3 and how they are treated. You should know where they may occur. I've included pictures because sometimes pictures are just helpful. And I also made sure I included pictures on different ethnicities. It's important to know how things look based on the patient's skin tone. Additional information to review. Please review shingles. Remember, shingles always follows a dermatome. Well, almost always follows a dermatome. It rarely crosses the midline. Look at cellulitis. The most prevalent cause is group A strep. That will help guide your antibiotic choice. Burns. You should know what degree a burn is and how to manage it and when to refer. And finally, fungal infections. Know when to use topical versus systemic. And finally, I'm just throwing this out there because I've taken boards several times and there's always questions about Lyme disease. In your clinical practice, you will see Lyme disease possibly, it's more based on your geographic area. Some areas you see it more than others. Patients will always ask you about Lyme disease. So I want to make sure you have an awareness of it. I also want to make sure that you know how to treat it and what symptoms to look for. Remember doxycycline. That's it. And just always make sure you have an awareness of whether or not you live in an endemic area. And finally, good luck on your exam. If you have questions, you know how to find me. And I'm definitely cheering for all of you. Good luck, guys.